Good afternoon, everyone. My name is Brianna Hansen. I am a program officer with New Jersey Healthcare Quality Institute. Thank you for joining today's learning session on our guide for hospital doula policy creation. Today, we will give you a brief overview of the work group's goals and objectives, give you a summary of the 2024 New Jersey Doula Policy Law, a walkthrough of each section of the guide, and conclude the meeting with a Q&A session. As a quick reminder, I hope you were all able to take a look at the guide before today's session. Let's foster a respectful environment where everyone feels comfortable sharing their questions. Throughout today's session, keep your microphone muted and only unmute during Q&A when prompted by our moderator. When you are speaking or leaving messages in the chat, please remember to use direct communication and make I statements. As we review the guide, feel free to leave any questions or thoughts in the chat. And during Q&A, please use the hand raising feature, which you can access through the Zoom menu bar, which should be at the bottom of your screen. And as a reminder, today's meeting is being recorded. The New Jersey Healthcare Quality Institute is a nonprofit, nonpartisan, focused on improving the safety, quality, and affordability of healthcare for everyone. And we would like to thank our partners on this project, HealthConnect One and New Jersey Doula Learning Collaborative. HealthConnect One is the national leader in advancing equitable, community-based peer-to-peer support for pregnancy, birth, breastfeeding, and early parenting. New Jersey DLC provides New Jersey doulas with billing support, education, training, and workplace development in service of birth equity. The goal of this project was to create a better climate for advancing birth outcomes and equity for doulas and their clients, as well as hospitals, their clinicians, employees, and patients by convening a work group to develop a guide for hospitals to use when creating their doula policies. The Quality Institute was aware of concerns that exist for both hospitals and doulas. Hospitals expressed that there was a lack of clarity within a highly regulated setting. And these concerns were heightened because as a community-based profession, the role of a doula is not licensed or regulated in our state the way many hospital clinicians are. And for doulas, the variation in policy, as well as the application of policy across and within hospitals, has been confusing, as well as creates barriers for them to access their client who wanted to have a doula on their birth team. For this project, we involved 16 hospitals and health systems representing 97% of the 2023 birthing volume in New Jersey. Here, you will see a list of types of hospital representatives that were involved in this process. We interviewed each hospital and health system individually for about 1 hour, then brought all of our hospital representatives together for a hospital-only work group, where we reviewed our findings and initial recommendations. Simultaneously, New Jersey DLC held focus groups with 16 doulas who serve clients across all 21 counties. 7 doulas were invited to meet with us individually and speak on their experiences as doulas with clients in New Jersey birthing hospitals. Like the hospitals, we brought the doulas together for a doula-only work group to review our findings and initial recommendations. We then brought both groups together for our joint work group, and hospitals and doulas provided feedback on our guide as it evolved. So after we had launched this project, Governor Murphy signed a law that requires New Jersey hospitals and birthing centers to have a written policy that allows a patient-selected doula to accompany the patient within the birthing facility's premises and provide support before, during, and after labor and childbirth. The law requires hospitals and birthing centers to provide a copy of their policies and procedures to various stakeholders and to post a summary of the policies in a conspicuous place, including inpatient maternity rooms and on the facility's internet, as well as designating a doula liaison. Next, Linda Schwimmer, President and CEO of the Quality Institute, will lead us in a walkthrough of the guide.
Thank you so much, Brianna. And I also wanted to just remind everybody again, if you could please take a look at the corner to make sure of your screen to make sure that you're muted. We are going to speak rapidly and cover all of the sections of the map. I'm going to start with the first 4, and then I'm going to hand things over to our HealthConnect One New Jersey Doula Learning Collaboratives to cover the last 2 sections. And then Keith Shamzad of the Quality Institute is going to moderate questions. And you can also put questions in the chat, but it will be really helpful if you could keep yourself muted as we go through these different sections of the guide. So the first section discusses doula policy implementation and internal education within and across hospital sites and departments. And I know that you'll read the guide on your own, so I'm really just going to highlight and frame for you some of the most important aspects of this section. We heard again and again in our work group the importance of maintaining consistency and clarity. So the recommendations include maintaining consistency in your doula policy across the health system's facilities and departments, and then applying that policy consistently. So not varying based on an attending clinician's preferences, but consistency was really stressed. The overarching ideal for the policy, and this is stated in the guide, is that the default assumption in the policy should be that a doula is allowed to be with their client throughout the patient's stay in the hospital. However, if there are specific reasons why your policy needs to differ from that, such as the physical dynamics of a particular hospital or a particular unit within the hospital, that should be stated clearly in the policy. And then the alternative should also be presented and stated clearly in the policy. We're also recommending that you provide education throughout your health system about your doula policy so that hospital employees across all of the different relevant divisions and employees of all types, as well as those who have privileges within the hospital but are externally employed, can be familiar with the policy, again, to promote uniformity and to reduce confusion for clinicians, hospital staff, doulas, and patients as well. As far as education goes, we recommend that there be education on the policy, and that education include background on the role and benefits of doulas, to help clinicians and staff really understand the role of the doula and the purpose of having a policy for doulas. And ideally, doulas can play an important role in both designing and providing some of those educational sessions. And when we get to the best practices session, you'll hear a little more on that. Again, this is something this is the dynamic space. And so it's a good idea to review and update your policy regularly, sharing it with doulas as well as recent patients for their suggestions and feedback on how things went and how you might adjust or improve upon the policy. So that's the first section. If you could go to the next slide, Brianna. So the next section is really the external. So I started with internal. Now we're moving on to the external distribution of your health system's doula policy. The doula policy, it's important to make sure that not only is it comprehensive and understandable, but that it's written at an appropriate health literacy level and that it's provided in the most common languages spoken by the perinatal patients at your hospital or who your system serves, so within your communities. The doula policy should be available online to all of the relevant stakeholders, which would include doulas, healthcare providers, patients, nearby reproductive healthcare providers, as well as WIC agencies, Connecting NJ, and the maternal consortia, who provide a lot of different programs and services. We also are recommending that any required forms that relate to doulas, doula support, either for patients or doulas, should also be available in advance online. So anything you're going to be asking the patients or the doulas to verify or acknowledge should be available for them to review in advance. There should also be a process where patients upon admission are offered either a paper copy or also a QR code with electronic copy or something in the patient portal. Again, just trying to think of all the various ways to try to make sure that people have access to the policies or anything that they're going to be asked to review and sign, so that it's truly informed agreement and consent and furthering understanding. And this is really so that you can sort of brag about what you're doing. Hospitals are encouraged to share their other policies and information about the ways that they're promoting physiological births. We know that a lot of hospital systems in New Jersey and other parts of the country have different aids or equipment that does promote physiological birth. It could be showers, tubs, wireless monitors, or other policies that really promote physiological birth. So it's a great idea to share that information in advance, as well as to have signs and other ways to have that information available within your birthing facility as well. Okay, so next section. Brianna. Okay, thank you. Okay, so then the next section, the third section of the guide, is the definition of a doula and the process for allowing them to enter the hospital. Doulas that are, that we know that doulas supporting their clients are arriving at the hospital at all hours and on weekends as well. So their entry into the hospital needs to be quick and easy. And that's really the goal here. So we are, the recommendations include a reference that doulas are expected to follow any hospital infection control and vaccination policies that are in place for visitors. And that information should be provided in advance. And again, it should be included in that policy that you're providing in advance. Hospital systems may ask a doula to acknowledge, either verbally or in writing, that they are trained or in training as a doula. But again, any type of acknowledgement or verification should be provided in advance, so doulas can submit those forms and move through the process of being allowed into the hospital quickly. If your hospital system does decide to use some kind of doula acknowledgement form, we recommend that the language that is used aligns, in our case, if you're a New Jersey facility, with New Jersey law. And that is the law that Brianna referenced at the top of the webinar, and the citation and the link. If you could mute, please.
How are you?
Hello, can you mute whoever's speaking? The citation is linked in the document. But specifically, it requires that hospitals have a policy and that doulas have training and are entering the hospital as a professional to support their client. And it goes on to describe that in greater detail. We are recommending quite strongly that health systems do not use a restrictive list of approved trainings to determine whether or not a doula is trained. That is inconsistent with New Jersey law, as New Jersey does not require a training from a specific training program, and does not have in the law, this law, a prescribed list of trainings. Just to clarify, for payment purposes today, Medicaid or family NJ Family Care does have a list of trainings that are required to be reimbursed. That does not go, though, to the definition of doula, and that language is not included in New Jersey's hospital doula law. So again, we are recommending that a health system not use a restrictive list of doula training programs. We are suggesting that health systems keep a directory or a list of doulas who have already completed the forms, again, to facilitate quick entry, and that if health systems want to facilitate things even further, they could consider doula ID cards or something like that. And then if health systems want to engage more intensely with community doulas, there's all kinds of ideas for doing that in the guide. Next section. Okay. Where are doulas allowed within the facility? Our work group spent a lot of time discussing this. We had a lot of input from both the doulas as well as all types of administrative people in various administrative roles, as well as physicians, nurses, midwives, and others. And where we landed and what we're recommending is that doulas should be allowed to be with their clients for all stages of labor, including triage, operating rooms, postpartum units, and NICUs. I will say, though, with the caveat that in cases of emergency cesarean sections or the use of general anesthesia, hospitals may have a policy that prohibits anyone from accompanying the patient or that imposes a one-person limitation. Additionally, if for some reason a facility, because again, for physical space reasons, if there are limitations within the facility that would restrict the number of individuals in the space, that should be clearly stated in the policy and explained. And that did come up. We had some facilities that were concerned based on the space and infection control goals. We also state in here doulas should abide by the health system's policy as they are allowed throughout the facility, and that they could be asked to leave or removed if they do not. For epidurals, the policy should be that doulas are allowed to remain with their client as long as they remain out of the sterile field, but they could be there to provide support. Same thing with other C-sections. If the patient is in a private or shared recovery area, they should be allowed to be there to support their patient by their bedside. And next, if a doula is initiating an activity with their client, anything that might involve food, drink, or plugging something in or unplugging something, the recommendation is that before taking action, that should be discussed with the clinical team, just so everybody's on the same page. Every situation is different with every patient, and that's generally a best practice. And there's more details in the guide on this, and then there's more details in the best practice section on huddles and how to discuss what the patient's preferences are, and just to get everybody on the same page to do what's best for the patient and that aligns with their goals. One recommendation in here is that to constantly improve, health systems might think about holding after-action reviews or debriefing sections post-birth with the care team, including the doula, just to see how things went, to continue to improve your processes. And we also reference the Healthcare Heroes Violence Prevention Act and suggest that you reference that in your policies. And at this time, I'm going to turn things over to, I'm not sure if it's Shanve or Joni, but somebody is going to take us through the next two sections.
Vanessa, come sit down.
Me.
And again, please mute yourself if you're not Shanve or Joni. Thank you.
Yes. So hello, my name is Joni James. I am a project manager here at HealthConnect One and the lead on this side. So really excited to talk to you all about the doula liaison. A few things. So we recommend that the health system should designate a dedicated doula liaison to facilitate communication and feedback among doulas, hospital staff, as well as clinicians. Because the liaison may not be on site at every hospital, health system should consider having at least several designated people to be available in real time as a doula liaison at different locations and for different shifts. I'm also a doula, so I understand, as Linda said, babies come when they want, and labor can happen at any time. In addition to this, if the health system does want to designate only one liaison, we recommend that they are someone who is familiar with holistic healthcare. So for example, another doula, a nurse, a midwife, a childbirth educator, or even a licensed clinical social worker. Or as terms of the activities, the doula liaison should facilitate activities to build relationships between doulas and the clinical team, for example, regular check-ins, as well as hosting doula orientations. Health systems should establish formal feedback channels for clinicians, staff, and doulas to address any concerns, improve collaboration and processes. Here at HealthConnect One, we say grows and glows. So things that are absolutely stellar that are working should definitely be highlighted. And if there are areas to be improved, things that can be worked on for growth. Lastly, the hospital doula policy should specify how issues will be identified and addressed if there are any concerns about a doula's behavior or interaction with a member of the clinical team. Next, we'll transition into additional best practice considerations for health systems and doulas. So doula education sessions. Invite the community. So partnering with local doulas and doula organizations to host educational sessions, for example, grand rounds, virtual presentations for hospital staff and clinicians to improve their understanding of and also the collaboration with doulas. This allows open dialogue and communication between hospital staff and not only just the maternity unit, but all staff. Strategies to improve clinician, staff, and doulas collaboration. So inviting the doulas to participate in staff meet and greets, using department meetings or even staff huddles, holding regular opportunities to connect and learn from each other during orientation, welcome receptions, and any other events that the hospital or health system is hosting. When there are doulas that are on the maternity ward, consider sharing their headshots and short bios for people to just notice, say, oh, hey, I recognize that face, I've seen that face around. If there is an opportunity within the health system to offer grant-funded doula programs, that is definitely a consideration that can be adopted for doulas to provide support to patients. Additionally, holding information sessions. So in the prenatal period, introducing patients to the concept of a doula, the role of a doula, explaining what the support and how they can be supported during their pregnancy and early postpartum period. And then, as Linda mentioned earlier, communicating about birthing positions and physiological birth. Health systems can provide visual posters or laminated cards that are in the actual birth room depicting birthing positions that can be used during labor. Implementing shared decision-making. So implementing a shared decision-making in the health system, patients should be able to share their wishes. So whether it's like a birth plan with the care team and also what they envision during their birthing process. And one thing that we would definitely highly encourage is the idea of a team birth. Hospitals that implement team birth have shown that there's an improved patient and clinician communication, as well as communication along with the doula. Additionally, team birth improves patient-reported autonomy and also respect that they feel with their wishes being honored. Lastly, there are some resources for you. So NYC's Doula Friendliness Capacity Assessment is a tool that you can use, as well as there are resources from the Doula Friendly Initiative and also resources that will be linked on soon to come landing page on HealthConnect One's website. Oh, last thing, and then holding a post-delivery care team debrief. So making space and the time for a discussion to be able to reflect on the birth, sharing insights, not only from the care team's perspective, but also from the doula's perspective as well. And then I'll turn it over to Kate for Q&A.
Thanks so much, Joni, and thank you to Linda and Brianna for your components of the presentation. I'm happy to facilitate questions and answers about the guide and the information that was presented, as well as any questions you might have about the process that we went through to create this. Please feel free to use the hand raise feature and I'll call on you, just because we have over 100 folks and it might be hard if you're taking yourself off mute without being called on, or you're welcome to drop your question into the chat if you'd prefer. So I see Christina, please go ahead.
Hi, thank you all so much, and sorry to not be on camera with you today. So this is really interesting, and in Massachusetts, where our doula organization is part of a interdisciplinary collaborative that's discussed the doula policy at the hospital. So I have a couple questions and concerns that came up as I was listening. One is, I know these are like recommendations or suggestions, but is the idea that every doula would go through submitting paperwork or some type of something at every birthing hospital that they wish to enter into to support a client, and that can easily become very onerous because that could easily be a multitude of hospitals, especially in states that are very populated. And two, if that's the case, and there's this like kind of pre-work, if a doula comes to the hospital, hasn't done it, is the guide recommending what to do in those circumstances to preserve the continuity of care? And then the third thing was, I heard about kind of like meeting with care teams, seeing how things went. And we've certainly done that with clinical care team providers. But I'm wondering, what if the doula witnesses something that shouldn't have happened from a care team member? Kind of what are the recourses to have that conversation? So those are my questions.
Thank you so much, Christina, and welcome from Massachusetts. I will field as many of those, but I would certainly welcome any of my Quality Institute or DLC colleagues to also jump in to provide answers. The intention with the doula acknowledgement is that is not an onerous process when a doula may be working at multiple facilities. It's really just a recommendation. It it isn't even required. It's just an opportunity for the doula to acknowledge that they've received and understand the policy there, so that everyone's essentially on the same page. And the goal is that those policies per state law are available publicly before the doula or the patient arrives for the delivery. So they would have been able to receive and review it, knowing which hospitals they may be accompanying their clients to. In regard to the role of the doula liaison, that certainly was a component of our conversations and our interviews with doulas and with all of the hospitals and health systems in terms of what happens if a doula has a challenge or a situation where they feel like their client was in danger or an unsafe situation happened. And all of the hospitals mentioned that there is a process in place should the doula, want to provide information about a concern, but not to the staff on that particular unit. They can go through the family relations department to be able to do that. But we also talked about the role of the doula liaison being really someone who's able to accept that input and challenges either from the doula or the hospital staff, and to be able to support those conflicts in finding resolution.
And I'll just jump in. It was specifically a recommendation establishing the feedback mechanism. That would be something that would be escalated directly to the doula liaison, who could then have that contact with the clinical care team to resolve any issue.
Kate, I'm going to read to you or read to everybody a couple of the questions that are in the chat and try to answer some of those. And then again, welcome our colleagues to answer as well if you want to add anything. So there's a question first from Lizzie about how are we planning on educating the staff in the hospitals that we exist, especially doctors. I think we is meaning doulas. That is our recommendation, that each hospital system itself educate their staff as well as the clinicians, doctors, nurses, et cetera, that they work with, who are either hospital employees or external to the hospital. And we did provide best practices on doing so. The Quality Institute plans to continue to work with New Jersey DLC and others in this education process. And we know that also there's other organizations, physician organizations, as well as hospital associations, et cetera, that are sharing this information. I don't know if anyone else wants to add anything to that. Somebody's saying that creating conversations and seminars at many locations, educating about doulas. Yeah, I mean, we agree, and that's definitely what we're recommending. The next comment is from Tashira, and it says community doulas work in the community for the birthing person, etc. How does this initiative keep the two separate and not infringe on advocacy and patient autonomy? So certainly there's no intention to infringe upon on that at all. There is an existing law, which is something that requires hospitals to take certain steps. And we put out this guide and worked on it across almost every birthing hospital in the state to try to have as much consistency as possible for birthing families, clinicians, doulas, and really anybody interacting in any way with for the birth. We were trying to provide guidance so that as many of these policies will be as consistent as possible. Do you want to go to some live questions for now, Kate, or should I keep going through the chat? There's a lot of them.
Yeah, happy to be managing both. We can alternate, certainly.
Okay.
I see that there's also some responses being typed into the chat too, so I appreciate that. But if you do want to ask your question live, please feel free to throw your hand up and we'll call on you.
All right, well, while folks are thinking, we can go to Sarah's question. Do you want to do that one?
Okay, so Sarah asks, how many hospitals in New Jersey agreed to some of these recommendations, interested due to expanding this fall and spring across central Jersey? I see that Brianna typed in there, but we did have the majority of hospitals providing birth support in the state. 97% of the births were represented at these 16 hospitals and health systems. And we say health systems, we mean really the large systems that have many, many hospitals. And so through the many iterations, both individual meetings as well as discipline-specific work groups and joint work groups, this document really is representative of a consensus statement. And so while we cannot, we can't be prescriptive to what hospitals put into their policies, we are very hopeful that everyone has come to the same consensus-driven agreement that this is generally what a doula policy would look like consistently across the state. And the law does require that the hospitals and health systems have that policy in place by July 1st.
So it's certainly our hope and intention that the hospitals that we worked with will use this as the basis for their policy. I'm sure that they'll all have certain differences, and would certainly welcome any hospitals who are on the line if they wanted to share anything further. But this is to support them in the efforts that they're making now to have a policy by July 1.
Shanve and Joni, I see two questions coming in specifically about doula training, and I'm going to yield those to you, but I'm happy to read them. It says, what platforms are there that list or identify doula certification sites, in-person and remote, in New Jersey and throughout the country? And are there any provisioning recommendations regarding doula training programs?
So you see, I'm getting some feedback. Okay, there we go. So essentially, as far as platforms that identify doula certifications or trainings, there's no one entity or body that lists all of them. There are a few different sites that have compiled a list. Our recommendation, and this is going into the second question as well, kind of getting two in one, is that organizations, when identifying doula training organizations, use a list of core competencies instead of identifying training certification sites. Essentially because it allows for innovation. At times there may be a specific group. I just came from a conference where there was an Indigenous doula training that was being hosted in Alaska. Most times you're not going to find that on a site that has gone through potentially Google or any other search engine, because that wasn't created specifically for that community by that community to serve the folks in that community. So we recommend using a list of core competencies when identifying, or for best practices when identifying a training agency, or if there is any plans to utilize it for Medicaid reimbursement, or to make it a rule in any way. So that is the current recommendation. And as far as providing student observations in hospitals, currently what we've utilized as well as other organizations is identifying preceptors that can be utilized in the hospital, as well as doula mentors that are currently practicing. Linking and partnering with community-based organizations is the best way to really have folks that can mentor doulas that have experience being a doula, 3 to 5 or more years of experience being a doula, that can be able to provide the mentorship and support that's needed for new doulas that are coming in and training.
Thank you, Shanve. And I think you might have captured this, but a new question just came in that says, a doula in training, would they need to be accompanied by a certified doula to attend a birth?
That's not a recommendation. Sometimes that depends on maybe a specific program or training organization, but that's not a recommendation that we made, is that they have to be accompanied by a specific person. We wanted to support the doula's autonomy as much as possible. So a specific mentorship program or a specific training organization may have that, but that's not currently a recommendation that we have or that we provided.
Okay, thank you. I see a question. Are there any resources, templates, or info about the process to get the law enacted that requires the doula policy? you know, none of the groups who worked on this particular guide were part of that legislative process, but I certainly would recommend that if you're in a state that's looking to create something similar, you know, absolutely use the New Jersey law as a reference. And of course, you know, we would encourage you to replicate a similar process that we went through. So you, if you do have a law in place, or even if you don't, that there is consistency across your birthing sites in your state to allow doulas to be able to engage and support their clients.
I would just add to what Kate said. One of the things that I think was very valuable about this process was some hospitals have a longer history of doulas providing support to clients within their facilities than others do. And so they really discussed their experience, asked each other a lot of questions, and learned from one another. And I think that process in and of itself was an additional benefit to the process of creating this guide. So I would recommend that to any state that's implementing a policy and then looking to have effective implementation and as much consistency as possible. I think a process like what we went through will put you in good stead for all of those outcomes.
And we're certainly, we don't want to bore the 100+ folks on here, but if you are interested in learning in more detail about the process that we went through and how that outreach and information gathering happened, you are welcome to reach out to Brianna afterward, and we can certainly connect with you. Shanve, I'm going to throw it back to you again. I see that Brian in the chat has asked more about the skill set of a doula, so those competencies that you were referring to.
Okay. So I see two questions. They kind of go hand in hand. The one before that says we have doula guidelines. Should we have a separate policy? I think that speaks to more so if there are specific guidelines, having that policy in place or having those guidelines in place so that a doula can sign off as an acknowledgement. That was part of the recommendation. So not necessarily a separate policy is needed, but if there are specific rules or regulations that the doula is expected to abide by in your facility, making sure that you're as upfront as possible in giving those guidelines to the doula, either making it publicly available on your website so they have access to that prior, or giving it to them upon admission. And Brian, in answer to your question, as far as I know, currently, skill set wise, the list of core competencies, I can speak more so to our training, HealthConnect One training, and a few others. Generally, there's no direct conflict with the requirements imposed by potentially collaborating hospitals. Doulas are non-clinical providers, so the education that's provided is more around, it's non-clinical education, it's more so around advocacy. And information and education. So generally, there is no direct conflict with requirements that I have seen. That's not to say that there wouldn't be. I would probably need to explore all of them, which I have not explored all of the policies. But so far from what we have seen from the health collaborating hospitals or health institutes, there's no direct conflict to any of these core competencies.
And I just wanted to add in back to Dawn's question about the doula guidelines. For this guide, we heard from all of the doulas and hospitals about all the different topics that they wanted to see addressed with respect to access, improved communications, better understanding and movement within the facility. And so you may have guidelines or you may have policies, but I would just recommend that you take a closer look at it and see if your guideline or policy or whatever you're calling it incorporates all of the different topics that we have included in this guide, because we tried to be very comprehensive. And these were the things that came up again and again, both for hospitals as well as for doulas. So use this as almost like a checklist, Dawn, is what I would say.
Ashley in the chat is asking, out of curiosity, is anyone at the state or is this group reviewing and providing feedback on the doula policies that health systems adopt after the July 1st deadline? That is a great question, and we hope certainly to continue to understand what's going on the hospital and health system level, and see what is in those policies. The good news is that everything will be public, so there will be access for anyone here to take a look. But I think that the group enjoyed being together and learning from each other, and certainly we hope to be able to continue that learning experience as hospitals implement their policies.
I think too, the fact that the state is continuing to fund some kind of doula learning collaborative is another opportunity for collecting that feedback. So, but it's a great suggestion and something that we're certainly, willing to support in some way.
If in the flurry of questions in the chat box, we missed yours, please feel free to ask it out loud or stick it back in the chat. I think we got to everything, but want to make sure we didn't skip anyone's questions. Okay, that's as long of silence as I am able to tolerate. Oh, we got in there. Tushira, thanks for sharing. Tushira shares that doulas have been around since the 70s and have always been non-clinical. The doula supports their clients to self-advocate and understand their rights. If doulas refuse to sign acknowledgements or provide identifying information, does this threaten community doulas who wish to remain autonomous and entirely supportive of the birthing person? I am not certain of how to answer that, but I'm happy to, Shanveg, for you to jump in.
I think I want a little bit of clarity as far as providing identifying information. I think anyone that enters into the hospital system has to provide at a minimum an ID, like a license. So are you speaking of that, or are you speaking of them providing training or certification? Because that was not a recommendation as far as them providing any training or certification. So I just want to clarify.
Okay, I'm sorry if I wasn't clear. I was referring to the first slide where it was the recommendations where they provide a bio, the picture, even providing their certification. Not every doula is certified, for one. It's an unregulated field, and as long as this is an optional thing, not every doula goes into the hospital wanting to be engaged. They're there to support the family. They're there to support that birthing person. And if they stay in their lane, there's no issue. They actually serve as a support person. Patients are allowed to have two people. So if they're not over the two people, because it's two people plus the doula in some cases, so let's just say it's just that person who happens to be the doula, well, they may not be wearing the doula hat. They could just be the support person. I guess I'm just, it seems very intimidating because, not everyone is going into the hospitals to create a stir. Some people go in, they do their job, they stay in their lane, they stay out the way. And our loyalty is to our client, and that client is also a patient and a consumer. And so as long as this remains optional in an unregulated field and it doesn't lead down the rabbit hole of now licensure and the certifications and who's, actually a doula over who's not, many people have been doing this work prior to the pandemic, prior to it becoming popular. And it just warrants some concern.
Thank you. So I think just an answer in reference, a lot of this work, especially what we saw, we first identified the problems that doulas were facing. We did a national survey as well as a local survey, as well as focus groups. And something that continued to be an issue was a lot of the relationships that were strained with the medical team, specifically maybe in regards to nurses. So when brainstorming different solutions, not only with the hospitals and healthcare team, but also with doulas, this came up as a potential solution, not a requirement at all. But one thing that we wanted to affect was a change in sort of the culture. A lot of times we see nurses and other practitioners, they don't know who is this person coming in. And that's a lot of times when you meet resistance, because the primary concern of all parties is generally safety. So in order to alleviate some of that stress and some of that burden, it's completely optional, but it usually helps build better relationships between the nurses that are on the floor, the OBs, when they know kind of who's coming in. I have a short bio. This isn't this person that's coming in that I've never seen before, that I don't know, how they were trained or anything like that. This is maybe Mary, who happens to live down the street, and our kids maybe go to the same school. This was more so about relationship building and collaboration, than trying to identify or putting anybody, for public on Front Street or anything like that. It had nothing to do with certification or keeping anyone out or having barriers or making this, again, a requirement at all. This was about just really uplifting collaboration and having a collaborative spirit between the doulas and the providers. And this is just one potential solution and one recommendation, not requirement, for the facilities to assist with that.
Well, thank you for clarifying that. But some practitioners and professionals, including nurses, already have their minds made up. There are some who are for doulas, and there are some who are not. No matter how many policies or recommendations you put in place, patients have the right to choose who they want in their birthing space, and the burden is not on the doulas to build relationship. Nurses have their, oftentimes I've seen it firsthand, and there's been many doulas who can attest. Sometimes it's the nurses that create the static. It's the system itself, because it can be intimidating. Perhaps we are there to educate. Perhaps we are there to support that parent who may say, no, that's not what I want. And they are empowered to speak up for themselves. And these are great recommendations, but they also come with a drawback. And as long as it remains optional, and as long as the autonomy, patients are not disarmed, and doulas are able to continue to serve the way they've been hired to do so, I guess we'll have to wait it out and see how this pans out. But we should also know it's the other side that hurts.
I wanted to jump in really quickly here. I know we're coming up on time. I see the hands that are raised. Thank you, Tashir, for your feedback. I think we're saying the same things. We're just looking at it from a different perspective. And I'd love to invite you just to think about it in just a different lens. We're not saying that doulas, and I'm also a doula, so I'm speaking to you from my doula hat. We're not saying that doulas will not be able to operate in the ways that they have been chosen by their families. Of course, birth work is definitely sacred. It is a sacred thing. This is just regulating how the communication can happen. So for instance, the things that you've mentioned in terms of your interactions with the care team, specifically nurses, with the doula liaison, with the specific policies that we recommended, this is the chance for you to be able to have a formal way to be able to document the things that need to be worked on to create better growth for the next doula, the newer doula coming in through the doors. So it's a chance for us to lay a foundation, a landscape, to be able to highlight the pain points I hear mentioned in what you're saying, and to create the atmosphere. Because most families in New Jersey, they're not having a home birth. They're going to the hospital. And there are many different hospitals, even within a health system. And there should be uniformity when you go from one hospital to the next. But right now, they're not. And we have to start somewhere. So I'm hoping that that was able to offer you some insight and support that. So thank you for letting me jump in.
Thank you, Toshir, for your comments. Oh, and Shanve and Joni. Yeah, go ahead, Linda.
I just say, I think I see two hands, and I think if they're quick questions, we have time for those two, and then we can wrap up.
Yeah, go ahead, Carly.
Hi, good afternoon, everyone. I wanted to comment on Tashira's comment. Not really a question, just perspective. So as a registered nurse, I love what you said about the right to choose. And when I saw from the lens that I was looking at it from the perspective of nursing, is that when you have a family that may ask for a doula, and you wanting to make sure that it's a good match for them, so it's supportive of the needs, there's specific needs that they're intentional about asking for that doula, the reasons for why they're asking for that doula. I think it's helpful, or what I've always thought is it's helpful to make a match so that they do have the right to choose based on who they're seeing with that doula versus the specific hospital or health system or that nursing clinician or navigator choosing for them. And so when I saw the bios and the interactions that the recommendations were making from the lens that I was sitting in, I thought, well, this is nice because then I can give that family the options and the right to choose the doula that they want to choose in the particular space and why they're asking for it. And then that support, similar to someone saying in the chat that, you can ask for a different nurse, you can ask for a different care team, you can ask for a different physician. They can ask for whomever they need differently in a space to support their needs. And that's sort of what I thought from the bio perspective, adding in addition to what someone else was saying about just offering communication needs, because I would hope that everyone interning in the hospital delivering this work during the day and age that we're delivering it is in the best interest of the families we serve.
Thank you so much for sharing your point of view, Carly. I appreciate that. Dara, I think you had your hand up, but it's down now. Did you want to jump in?
I did have my hands up, but I think it was already addressed. I was just stating from a doula's point of view, I think that this actually protects us in a sense of when the comment was made that sometimes different providers may not want to acknowledge doulas or nurses may cause the static, that this is a nice way for us to say that this is the policy, this is what was outlined, and having something to actually be able to refer to make sure that we are able to support our patients appropriately. I think that this is actually something that's really going to benefit doulas and help us integrate into the health system.
Thank you so much for your comments. I know that there's been a lot of back and forth in the chat, and I appreciate those who are jumping in to answer each other's questions. I'm going to call on Rachel, and that will be our last question before we wrap up. So go ahead, Rachel.
Hi, good afternoon. I think that what feels like what's going on is you're an entity that has significant power. So when you create a policy, even with all voices, and we hand it to a hospital that says, these are our recommendations, the likelihood of those hospitals adopting any of these is probably pretty high and significant. And there already is a significant power dynamic between the hospital system, the parents, and the doulas. And I think it just feels a little top heavy in kind of giving parameters to tell the doula what they can and cannot do. And that ultimately the hospital holds the power in that if they don't like you or you don't cooperate or you do something that's outside the box, or maybe you're a new doula and you tried something and you forgot you had to ask. I think that there's a power dynamic that's not being addressed in these doula conversations in New Jersey. And there is one going on here right now. And so when we have these policies from organizations that are well respected in the medical community, it creates another power dynamic, and the onus becomes the labor, the hard work becomes on the doula in the family. It's not on the medical provider because they have everything that they've wanted. And it becomes on the family and on the doula to now navigate this and have more labor on this, more labor on us when we just want to show up and support families. So that's what continues to keep happening are the power dynamics that happen between doulas, the community, the family, and then all these organizations that are making regulations or policy changes. And it just in sacred work that was shared here. In sacred work, it can feel really weird to have all these systems trying to come in and kind of like gaslight our work, sort of, or like tell us what we're doing when we were trained, we know what to do. It just, the system doesn't really feel or isn't comfortable with our work. That's the real issue. It's not the doula, it's the system.
Thank you, Rachel. I appreciate that you're sharing your views and that you're comfortable doing so. And I can see from the chat that there's certainly some agreement with them. I can say, you know, the Quality Institute came to this work because we know that across the state, there's a lot of interest and enthusiasm for doulas. There's a lot of interest in having health insurance companies, both in Medicaid as well as commercial markets, reimburse doulas for the work that they do. And there's growing interest in having doulas support their clients within hospital facilities, because there really just aren't very many birthing centers in the state of New Jersey, frankly, and also because insurance doesn't reimburse for home births. So thinking about trying to make an equitable environment for people, as many people as possible who want to choose their own doula, to be able to have a doula, you know, that is really our goal. And looking at, we started working on this before the state created a regulation or a law that said that hospitals have to have a doula policy. But we continued on with this work once that law was passed, because we wanted to make sure that we had focus groups of doulas, interviews with doulas, as well as hearing from hospitals which frankly are one of the more regulated places on our planet. We wanted to hear from everybody as to what their concerns were and what their priorities were, so that we could provide input to hospitals as they were creating these required policies. So I hear what you're saying. I understand it to some extent. I'm not a doula, so I want to acknowledge that. But I think we also have to really understand that if we want doula services to be something that are accessible to a broad group of people and something that are covered by insurance and that are accessible in a lot of the birthing hospitals, that we need to do our best to try to incorporate all of these concerns and to try to create a lot of consistency in how to best support birthing people in their choices and decisions. So I hear what you're saying, but the work that we were doing was really looking to support the implementation of these and execution of these policies. So it's always trying to find the right balance. And I hope everyone understands the spirit to which we come to this. And again, this is a growing field. It's an iterative process. We think that the guide that we produced is of excellent quality and comprehensiveness, but we know that we will continue to learn. So, and we appreciate all of the comments and support you guys are making. And I'm sure tomorrow's guide will look different from today. Just like so many policies around these topic areas. So thanks for being part of this. We're going to send out the recording and the slides to everyone. You all have the guide. And again, thank you for your contributions to this work and for what you do every day on behalf of your clients as well as your patients. Thanks again.